Welcome back to the channel, guys. Thanks for checking out the video. Today we're doing something a little bit more professionally done. So I'm doing this presentation actually tomorrow for my rotation, but let's have Mitchell tell you what's our channel about before we get into the video.
All right, so welcome back. So our channel is Getting That MD for anybody who's tuning in just now. We are talking everything about medical degrees, but you're gonna hear and see us go through our applying into and trying to get into medical school. So join us on our trip and then watch some of our videos, and hopefully you learn something new.
Yeah, thanks for the introduction, Mitchell. So today, as it says, more professionally done, because you can see by this intro slide. So this is the updated guidelines on treating extended spectrum beta lactamases, enterobacterials, or ESBLEs. I know on this channel we have not talked about this topic yet, so I'll do more introduction videos into this topic for bacterial resistance. But this is very important because doctors are overprescribing fluoroquinolones for UTIs, infections like that, when you can use medications like Bactrim. So what was that side effect for fluoroquinolones, Mitchell? So we remind our viewers why we don't like them.
Oh, I freaked out. Well, I didn't freak. Well, yeah, tendon rupture,
And
and I believe you said irreversible peripheral neuropathy.
exactly. So we're worried about that.
Irreversible.
So the guidelines have been updated on this, and doctors still aren't following the guidelines. So this is why this video is so important. With that said, let's get into the objectives. So we're going to review the background of ESBLE infections, discuss treatment options for various ESBLE infections, which I've also alluded to in our previous videos already about what you use for it. Something we haven't done on this channel yet is evaluating primary literature regarding use of antibiotics. So primary literature is just, how would you describe primary literature to our viewers?
Well, I whatever we use to find the information.
Yeah, so primary literature is basically like studies that are done. So people get IRB approval, which is like the International Research Board approves their
Which
project.
takes
They do
forever.
studies. It takes a day now. Hang on here.
Oh yeah, that's right. You told me because when I did it, it took like forever.
Yeah, they updated how you get IRB approval now, so it's pretty quick now. But anyways, let's get into the topic and let's do it. So for the background, so the incidence of ESBL infections has increased from by 53% from 2012 to 2017. It's 2021. This is probably increased by now. So
Yeah, probably like 60 or 70.
yeah. So you have common ESBL pathogens, so that's E. coli or Escherichia coli. It's E. coli. No one spells it out like that. Klebsiella pneumonia, Klebsiella oxytoca,
That's
and
just lab, right?
Proteus mirabilis.
Yeah.
So this is a little bit more advanced than our channel is used to. So there's a CTXM enzyme, which is an enzyme the bacteria makes.
I'm
That's
just making
called,
my own man.
it's M15 is the most common one, and this is what
Mhm.
kind of inhibits the medications. So I guess before we get into the topic, I guess I should explain ESBLE. So
Please.
yeah, so bacteria, as you know, we use penicillins and cephalosporins, right, Mitchell, for
Yeah.
infections. They carry a lot of bugs. You also have zoosin, so it's piperacillin tazobactam. This covers a lot of bugs. This covers Pseudomonas. This is like the most common medication used in the hospital, so doctors use it all the time. But if you have an ESBLE pathogen, that medication will not work. Will not work. They'll be given that empirically. They'll think it'll be working because it's normal pathogen. It won't work. So the patient might die. So that's kind of why it's so important. So this is more of just how you define it. So CLSI, which is like the resistance, like I guess how you explain them is they kind of make the breakpoint. So if there's a concentration of a drug over this and that, the drug works. So that's kind of what they say most of the time. So they define ESBLE as resistance to ceftriaxone, which is a third generation cephalosporin. Easy as that. At the hospital I've been working at for my rotations, they use cephalosporin plus cavulanic acid on a Kirby Bauer disc. You know,
Hmm.
remember those, right? We messed around with those in
Uh, yeah.
microbiology.
Yeah, that's why I say microclass because I was reading ahead.
Yeah. So basically, if they inhibit the bug, like makes a zone around it, it's ESBLE because the clavinic acid will inhibit their that type of dude. So that's basically it. That was kind of more complex. And if you notice, there's reference at the bottom of the slide now. So if you ever want to go back to it, we're on the background slide right now. You can literally just look that up. That number on the bottom, DOI number. You can read the article, or the guidelines where this came from. So treatment of uncomplicated cystitis. As we said in the previous video, nitrofurantoin, Bactrim. Cool, right? ESBLE infections, they work. There's no reason to use carbapenems or fluoroquinolone. As we said, tendon rupture. Not good. You don't want a tendon rupture. I don't want to hear you complain about your tendon ruptured. Stay out of the hospital.
You also don't want
Avoid it.
permanent peripheral neuropathy.
Exactly. You don't want any of those. So how about we avoid using them when we can? How does that sound? So carbapenems, fluoroquinolones are effective against ESBLE. However, you want to say these for future infections to limit toxicities such as the side effects of fluoroquinolones. So as you see on the screen, this is a study from November 12, 2007. There's a short course of nitrofurantoin for the treatment of acute uncomplicated cystitis in women. It's a little bit of information about the study. Again, it's the first time I've done this on this channel, so bear with me. I'll go slower through these in the future, but on time's sake, I'll go a little faster through this one. So it was an open label treatment of 338 women with acute uncomplicated cystitis. They received either macrobid or Bactrim. So nitrofurantoin or a combination product, really. So open label just basically means they weren't blinded, so they knew what they were receiving. Makes sense? Do you have anything to add to that part?
No,
Okay.
no, it's pretty understandable.
Okay, I was making sure I wasn't confusing with open label, which is basically
When
saying,
you compare to a double blind or single blind, yeah.
yeah. So other studies can be double blind and single blinded, which means if it's double blinded, the people receiving the drug don't know what they're receiving, and people giving the drug don't know what they're giving to the patient. That just helps
And
prevent
open label
bias.
are due for long term, right?
Open label just more, I think, for
To assess long term.
I think it's like for
Toward
ethics, really. Like if you're
okay,
treating people, I mean, it's an older study too, so maybe they just don't want to blind people. They want people to know what they're getting. I don't
right.
know. Anyways, for the results, so clinical cure was achieved in 79% of people in the Bactrim group and 84% in the macrobid group. A 5-day course of macrobid or nitrofurantoin is equivalent clinically and microbiologically to a 3-day course of Bactrim. So that's kind of interesting to see that a 5-day course of one drug is equivalent to a 3-day course of another drug. Pretty cool. I do say so myself. So you have another study. So amoxicillin clavinic is augmentin, which I'll refer to it for now on, versus ciprofloxacin for the treatment of uncomplicated cystitis in women. Randomized trial. So this was not open trial. This was single-blinded, randomized trial. You have 370 women aged 18 to 45 with symptoms of acute uncomplicated cystitis, and it goes into more detail about like the urine cultures. But for sake of that, they have a UTI. They're single-blinded. They're receiving medications, right?
Mhm.
So 58% of the people treated with augmentin got the clinical cure versus 77% of people treated with ciprofloxacin. So basically, the takeaway from that, augmentin was not as effective for it. Oh, here's that. So you have treatment of pyelonephritis, which is your kidney. That's where it's at. Complicated urinary tract infections. This is again ESBLE still. You see the common trend here, Mitchell? It's Bactrim.
Yeah.
It's Bactrim. It's the common trend. That's why I kind of like emphasized in our UTI video that Bactrim's really important to know. So, or ertapenem, meropenem, or imipenem celastin. That's a combination product of a penem and something else that inhibits ESBLE. You have Cipro and levofloxacin again. Again, fluoroquinolones. You can use them. I wouldn't recommend it. So that. And then
But you would think some doctors would be up to date. You can't blame for not being up to date, but at the same time, they should be up to date. So it's kind of like a double conundrum.
well, the problem is they should be up to date, but you also have pharmacists who are up to date and they yell at the doctor. And the doctor's like, no, this is my job. You stay in your lane, I'll stay in my lane. And the pharmacist is like, no, this is the patient we're treating. We're not giving him this drug. So.
If I ever act like that, please slap me. Use you, not anybody else.
Just me? Slap.
Yeah.
So then again, you have another study that backs up what I just said. So again, citations on the bottom of the screen. So you have oral treatment options for ambulatory patients with UTIs caused by ESBLEs and E. coli. The purpose was to evaluate the antimicrobial agents used in the outpatient setting for UTIs. And then you can see like what they were susceptible to. As you see down the bottom, you have fosfomycin. 94% was susceptible to it. And this is still an older study. It's 2005, 2007, so it's probably out to date. They have nitrofurantoin, Genta. Yeah, it's Cipro on the end. That just shows like some of these treatments aren't as good as we think they are. So you can see some were
We need
not
more
too good.
research.
Yeah,
We need more. And to get
do
research, we need money. We need more funding.
more funding. And again, I talked about this before. If ESBL infections outside the urinary tract, use a carbapenem. I mean, there's really nothing really you can use for that. There's ertapenem, meropenem, imipenem, celastin. That's that. Carbapenem outside, inside urinary tract, probably Bactrim. You can use fluoroquinol if you want. But so this study right here, the effect of piperacillin, tazobactam, or Zosyn versus meropenem with 30-day mortality, is a very important trial that we will go in detail with eventually. So it was a non-inferiority trial, so basically trying to see if one drug's not inferior to another drug, so meaning they're on the same level page. That makes sense?
Yeah.
Okay. I just want to make sure I'm not confusing people with fancier words than we use in our other videos. So non-inferiority is trying to see if one drug is equal to the other drug, pretty much. Make sure they're about working the same. And 379 patients. So 12.3% patients that got Zosyn met the primary outcome of mortality at 30 days, compared to 3.7% patients in the meropenem group. Now, you see the issue here with that?
No, please explain.
Yeah, so you have almost 9% of patients dying. 9% more patients are dying on Zosyn. That's bad. As I mentioned at the
That's
beginning of
not
the
as
video,
good. That's messed up.
Zosyn is one of the most common medications used in a hospital because it covers a lot of stuff.
Yeah.
So doctors have mixed feelings about Zosyn and ESBLE. This is a more recent trial. So before this trial came out, if you had ESBLE, doctors assumed Zosyn was going to work. This trial was stopped early because 9% more patients were dying on Zosyn. It was critical for infectious disease, which we'll do a better and more detailed video on it later on. That's it for this video, guys. This is a very complex topic and it's very detailed. So we had to split it up in 2 videos. So
Check us for the next video.
yeah,
Have a
we'll
good
see you
one.
then.